Good morning, good afternoon, good evening, everyone. I'm Sergio Aparicio. I am the current president of IFSO Latin American chapter. It's truly my pleasure to welcome you, everyone, and to present this important event for us. This is the IFSO webinar in charge by to IFSOLAC. We are going to listen this morning something about obesity surgery and hypertension. Thank you to Dr. Marcos Berry. He's going to moderate this webinar, and I let you in charge of this webinar, Marcos. Thank you.
Thank you, Sergio. Thank you all. Good morning, Latin America. Good morning, North America. And good afternoon, Europe, for all our colleagues from there that are watching now. We have a wonderful and very important topic this morning. It's called long-term results of bariatric surgery on obesity-related hypertension. We have two world-class speakers. They're going to share their knowledge with us. And then we have also two world-class commentators or panelists at the end. We're going to start with the two talks from Dr. Claure and Dr. Escabion. About each of them has 20 minutes to present. After that, we're going to go on with question and answers with the panelists and with the audience. So if you have questions, please write them out and we're going to share it at the end. So we're going to start this webinar. Thank you, Dr. Aparicio, also for the invitation from LATAM, IFSO LATAM. We're going to start with Dr. Rolando Claure. Rolando Claure is a MD and PhD from Cochabamba, Bolivia. I'm looking for his, here it is, his CV. He's a postgraduate training in nephrology, a fellowship in nephrology and internal medicine, and in the US, in University of California. And currently he's a professor of medicine, clinical research investigator of the Biomedical Research Institute, and director of the nephrology division of one of the hospitals in Cochabamba, Bolivia. Thank you, Rolando. And he's gonna share with us the first talk that is called Hypertension in Obesity, Epidemiology, Physiopathology, and Treatment. Dr. Claure, welcome to this webinar.
Thank you. Good morning and good afternoon, everyone. I want to thank IFSO LATAM for the kind invitation, especially Dr. Sergio Aparicio. So I'm going to cover the topic of epidemiology, physiopathology, and treatment of hypertension related in obesity. These are my disclosures. So in the next 20 minutes, I'm going to cover these points. First, I'm going to show you the magnitude of the problem and show some data about epidemiology in different regions and countries. Briefly talk about the pathophysiology, then what should be our treatment goals in terms of weight reduction, how useful is the medical management, how you should manage your blood pressure control, and I'm going to end with some data about the impact of metabolic surgery on obesity-related hypertension. I'm going to end with some conclusions. So obesity and overweight is a really big problem. These are the key facts published at the website of the WHO on 2022. You could see that 1 in 8 people in the world were living with obesity, but that year, worldwide adult obesity has doubled since 1999, and adolescent obesity has quadrupled. By 2022, 20.1 billion adults were overweight, and of these, 890 million were living with obesity. And this problem is also impacting our children and adolescents. By 2022, 37 million children under age 5 were overweight. Over 390 million children and adolescents aged 5 to 19 years were overweight, and from them, 160 million were living with obesity. So really it's a big problem. In terms of obesity and related hypertension, this is data from the US. We're gonna first go to the US and show you some data of this country. You could see the hypertension prevalence and obesity prevalence is high, especially in the age between 18 to 39 years. And both hypertension and obesity has increased from the 1990s through the 20s, with a big increase, especially in that group age, to 45% in terms of hypertension. And in terms of obesity, the increase in percentage has also been high and is higher than 60%. So really a big problem. Let's move to Asia. This is a study from Bangladesh done in 2 universities. They address metabolic and anthropometric measures, and if the staff of these 2 academic institutions have hypertension and overweight. And you could see that abdominal obesity is a really big problem, especially in female population. 64.1% of the female population in these 2 universities had abdominal obesity, and hypertension was 25.6%, and in males 36.9%. And the age group that was most impacted with these 2 problems was the population that was between 41 to 50 years old. Let's move to Africa. This is a study from the Northern Sudan, done in June of 2021 with more than 1,000 participants. They collect data in obese and overweight patients older than 18 years, and they took some anthropometric measures, and blood pressure was obtained in 2 time points. You could see, again, a really big problem. 86.3% of the population was obese, with a prevalence of hypertension in this population of 79.3%. Let's move to Latin America. Really big problem in our region. This is data from several countries in our region. In Brazil, there is a prevalence of obesity of 20% in men, and in women 20 to 30%. In another urban-based population study with more than 7,000 individuals that were enrolled, and that covered 3 countries, Chile, Argentina, and Uruguay, central obesity was present in more than a half of this population. And it is increasing. The largest increase in mean BMI from the 1970s to 2014 was present in Central Latin America, with an increase of 1.27 of BMI per decade. And the prevalence of hypertension is also high. In Brazil was 20.5%, and in Argentina, 14.9%. In terms of central obesity and hypertension and a risk factor for adverse events, this again is an observational study, big study with more than 60 countries that participate, and that include many countries of our region. And you could see that central obesity is associated with an increased risk of cardiovascular adverse event and increased risk of developing type 2 diabetes. What about the pathophysiology? The effect of weight gain increases the frequency of developing hypertension through years. You could see that obesity produces some hemodynamic, neurohumoral, and renal changes in obese humans. And these changes are similar also in experimental animal models of obesity caused by a high-fat diet. You have obviously increased arterial blood pressure, your heart rate increases, your cardiac output increases, you have structural changes in the heart, like, for example, cardiac hypertrophy. your diastolic cardiac function decreases. You have alterations in your renal function. You have a phenomenon of hyperfiltration, proteinuria. It increases sympathetic activity in renal that would drive increased sodium reabsorption, increased levels of plasma insulin, decreased insulin sensitivity, and increased levels of plasma leptin. So the physiopathology of obesity is multifactorial. You have a genetic predisposition. For example, it has been found some genetic polymorphisms that increase the adrenal receptor sensitivity. You have a lot of physiological disturbance. For example, you have increased sodium sensitivity and reabsorption, increased sensitivity to the RAS system, expand plasma volume, increase oxidative stress, for example. Also, you have some biochemical alterations like hyperinsulinemia, insulin resistance, hyperleptinemia, dyslipidemia, glucose intolerance. And in the kidney, there are some anatomical perturbations. Fat infiltrates renal, causing causing kidney compression, and this will impair renal pressure natriuresis, increases intrarenal pressure, and causes glomerular hyperfiltration with proteinuria, and also in some cases the development of glomerulonephritis. These all alterations in conjunction could cause a sympathetic overdrive with the final endpoints of vascular dysfunction, adverse metabolic events, cardiac dysfunction, renal kidney dysfunction, and neuroendocrine imbalance. In terms of kidney disease and development of CKD, who could in turn increase the risk of developing CKD and increase blood pressure with increased need of more anti-hypertensive medicines. Physiopathology is the main driver, is the visceral obesity. Here you could see those two images of obese dog kidney and mouse obese kidney. You could see how fat infiltrates the kidney, causing renal compression that will drive increased renal sodium reabsorption, impairs macula densa feedback with afferent arterial resistance, and the phenomenon of glomerular hypertension. This would increase the risk or will develop patients will develop chronic kidney disease, increasing blood pressure or increasing the need of antihypertensive medicines. So what should be our treatment goals? Our primary goals should be weight reduction, with the primary focus to lower blood pressure and improve overall health. We need to achieve a target blood pressure level to reduce risk of complications, especially cardiovascular complications. The target blood pressure control is under discussion. Recent KDIGO guidelines on treatment of hypertension in CKD lower this level to 120 to 80, but I think this should be individualized. Finally, we should address both obesity and hypertension through lifestyle changes, medications, and possible surgical interventions like metabolic surgery. So what's the effect of weight reduction programs like diet, exercise, etc.? This is an interesting systematic review that analyzes different treatment strategies for overweight and hypertension. It analyzes prospective studies and randomized clinical trials from patients with a BMI equal or higher than 28 and weight that at least were followed up for 2 or more years, and where weight changes were recorded. Shorter-term studies usually show that for each drop in 1 kilogram of weight loss, you will have a drop in 1 millimeter of mercury in your blood pressure. Surgical intervention studies show a huge weight loss after the surgery, but this has not a dramatic impact on systolic and diastolic blood pressure differences. You could see in these 4 studies that I'm showing here in this figure. In this study, when you took out the surgical interventions, or these treatments were excluded, and the models of other intervention, medical intervention, etc., show that for every 10 kilograms of weight loss, you could have a decrease of 4.6 millimeters of mercury and 6 millimeters of mercury in your diastolic and systolic blood pressure, respectively. So what's the impact of these weight changes, diet, exercise, behavioral changes, etc., on our patients with obesity and hypertension? They have a reduced impact in weight loss, and also a reduced impact in reducing your blood and diastolic blood pressure, with reducing no more than 10 millimeters of mercury of systolic blood pressure, for example, in this study published in 1995. And also there's a blend of with time of this weight loss with these medical measures like diet, exercise, etc. There are some factors that reduce or blunt this initial weight loss, like the obesogenic environment we are living, like, for example, the intense marketing of energy-dense foods, increased availability and increased portion sizes, high-stress society, etc. You could also have changes in hormones following weight loss. There is a trend that favors weight regain by increasing hunger and promoting energy storage. There are also some compensatory changes in energy expenditure. Also, you have some issues with nutrient metabolisms. Some studies in humans, for example, have demonstrated that post-obese individuals have low rates of fat oxidation and suppress postprandial fat oxidation. And also there's an increase in subjective appetite. So not very helpful measures, but I think it should be part of our treatment goals. In terms of medical management, again, from the same systematic review, I'm showing here 3 randomized controlled trials that have compared placebo plus diet versus 2 drugs, orlistat or metformin, that was not complete to placebo, but was compared just with diet. Again, low weight difference after this treatment were initiated, with a small impact on systolic and diastolic blood pressure difference. And for example, in this randomized controlled clinical trial, diet was more effective than metformin plus diet. There's a new drug that I think should be used and has great impact in reducing adverse cardiovascular outcomes and kidney outcomes. That's these GLP-1 inhibitors like semaglutide. This is again a systematic review and meta-analysis recently published that compass 6 RCTs with more than 1,500 participants. Participants didn't have hypertension, but were obese or were overweight with associated conditions that increase the risk of adverse cardiovascular events. They didn't have diabetes. They have a decent follow-up period, and patients receive in these clinical trials those range for weekly semaglutide that range from 0.05 to 2.4. You could see they have a good impact in reducing blood pressure. Systolic blood pressure was reduced close to 5 millimeters of mercury, and diastolic blood pressure was, the reduction was close to 2.5 millimeters of mercury. The effect on chronic kidney disease progression, adverse cardiovascular event is also high in patients with obesity and hypertension. And this study that was published this year is very important, and of the use of this type of medications in controlling weight, reducing adverse cardiovascular events, adverse kidney events, and also helping controlling hypertension. This is the FLOW-TIDE study, was an international double-blind placebo-controlled ran in 28 countries. They include 2 groups of patients with different stages of CKD and increased risk progression of CKD. The median follow-up was 3.4 years. Major adverse kidney events that include doubling serum creatinine, need of dialysis, transplant, etc., was reduced with the use of semaglutide in 24%. Death from any causes was also reduced by 20%, with no adverse events that were different compared with placebo. So this is extremely useful drug that should be part of our medical management of these patients with high risk of cardiovascular complications, CKD, hypertension, obesity, and metabolic disorders. What we should use to control our blood pressure in these patients. So looking back to the pathophysiology, we have 2 first-line medications. The first line should be RAS inhibitors. They also reduce kidney adverse events, as we have been using these medications for many years, and also could improve insulin sensitivity. The second line medications would be calcium channel blockers. They also have effects on glucose metabolism and weight gain. And there's a place for the use of MRAs if you think in the physiopathology, but no studies have explored this association. There's also some issues when you combine these that you should be very careful, especially in the CKD population, with the potassium control. Beta blockers should not be used as a first or second line therapy, except in patients with heart failure and post-MI. If you are going to use beta blockers, third generations beta blockers should be used, like carvedilol and nevidolol. There's an issue with this type of antihypertensive medications like weight gain and insulin resistance. And you should avoid thiazide diuretics because they could cause insulin resistance and this lipidemia. They also increase uric acid levels, and you should avoid, especially use combinations that are in the market, especially with RAS inhibitors and thiazide diuretics. What about surgery? Metabolic surgery is very useful, and these are 2 systematic reviews and meta-analyses that were published recently. This is the one of best 73 studies and close to 20,000 participants that include different types of metabolic surgery. And you could see that in a follow-up between 3 months to 15 years, 60% of the patients improve in terms of hypertension. Another meta-analysis with 57 studies with more than 50,000 patients, again, showed improvement more than 63% in hypertension following metabolic surgery, with a follow-up that ranged from 1 week to 7 years. However, benefit was not observed in many of these studies, especially in studies where the long-term follow-up was higher than 5 years. In a recent study, that was a cohort study with 197 patients who underwent these 2 types of metabolic surgeries, YGB or SG. The relapse of hypertension was more than 20% after 3 years of follow-up. The main predictor of relapse was the number of post-op antihypertensive medications that the patient were receiving.
Rolando,
yes.
Rolando, you have one minute, please.
Okay, yeah, I'm gonna finish. Just thank you.
Okay.
In this recent randomized single center non-blinded trial, metabolic surgery was plus medical therapy was compared with medical therapy alone, and the primary endpoint that was the reduction of more than 30% in the total number of antidepressant medications and achieving blood control lower than 140/90. At 12 months, metabolic surgery was more effective than medical therapy alone, with a reduction even at the first month of this study protocol and with a reduction on the number of medications. We have analyzed, this is our group that is working in Clínica Los Olivos, led by Dr. Aparicio. This was submitted as an abstract for the upcoming ASN Kidney Week meeting. We have 82 patients, different types of surgery. We follow up the renal function measured as CKD eGFR, and you could see that after metabolic surgery, the eGFR improved in patients with a follow-up of 12 months. Also, we found a decrease in albuminuria and proteinuria in these patients, and also a decrease in systolic and diastolic blood pressure. So, in conclusion, the management of obesity and hypertension needs a multidisciplinary approach. It's extremely important to establish working groups, and that should have a collaboration between primary care physicians, dietitians, cardiologists, nephrologists, endocrinologists, and mental health professionals. We are fortunate to have that one in Clínica Los Olivos. We need to customize treatment plans focusing on individual patient needs and preference. Combating obesity-induced hypertension requires a holistic, multifaceted approach. And finally, patient education and support is essential for long-term success and improvement in quality of life. And with that, I will finish. Thank you for your attention.
Thank you very much, Rolando. Excellent talk, excellent topic, and very comprehensive. We're going to make comments at the end. We're going to continue now with, it's my pleasure to present Dr. Carlos Schiavon. He's a famous and well-known and a friend from Brazil. He's a bariatric and metabolic surgeon at the Center for Obesity and Bariatric Surgery at the BB Hospital, and president of the NGO Institute Obesidade Brazil. And Carlos is going to present to us long-term effect of bariatric surgery on hypertension, control and remission update of the Gateway study. Go ahead, please, Carlos.
Marcos, thank you very much for the presentation. Thank you, Aparicio, for the invitation, for all my friends from IFSO LAC and IFSO Worldwide. Hi, everybody. I'll say something about my trial and some updates and some highlights. I included some highlights from all the publications. My disclosure for this presentation is a research grant from Ethicon. And first of all, I would like to say that this paper published in 2012 was an inspiration for the Gateway, because it showed one of the first times with very big numbers of patients that bariatric surgery could reduce blood pressure. And this is a very important paper. In 2014, we published the design paper of the Gateway study. I would like to say that we said at that time obese patients, and we should modify this. We should say patients with obesity. But we started the Gateway in 2013, and the design paper was published in 2014. The baseline of our patients, I think it's important to say, patients with obesity grade 1 and 2, the mean BMI is around 37, the age of the patients is around 43, 44 years, and most of the patients were females. And all the patients entered the study with the controlled blood pressure. You can see here, this is data from baseline. And all the patients were taking at least 2 medications in full doses. The median number of medications, antihypertensive medications, were 3 for both groups. This is the primary endpoint of Gateway, reduction of at least 30% of total antihypertensive drugs, maintaining the blood pressure based on the Brazilian guideline, under 140 over 90 millimeters of mercury. I think this is a little strange for most of the people, this endpoint, but that's we decided at that time when we designed the paper. And some secondary endpoints that I will show you: metabolic and inflammatory profile, blood pressure, office blood pressure. And this is very important because it's the first randomized trial with hypertension and ambulatory blood pressure monitoring. Apparent resistant hypertension, a very important topic for nephrologists and cardiologists, and remission of hypertension. I'll show some highlights of the first and third year publications. This is, I think, it's a very important highlight from the first year. You can see here this column in blue is patients who achieved the primary endpoint, around 80% in the first month, before a huge weight loss. And that shows us that the amelioration of blood pressure, the reduction in the blood pressure, occurred before the weight loss. And something is happening after metabolic surgery beyond weight loss to help patients control the blood pressure better than patients not operated. This is a very interesting point, and we should study this much more. Another highlight from the first year, the common limb, the common channel of our patients were variable because the alimentary limb and biliopancreatic limb were fixed. And we studied at that time if the common limb impacted the hypertension remission, if there is some relation with the common limb channel length and remission of hypertension. And we showed, it's published in short, that there was no relation with the common limb length and hypertension remission. Patients with remission and patients without remission has similar common limb length. This is interesting because we discuss a lot the limb lengths, and this is important for the surgeons. Another publication from the first year, for the first time, a randomized trial showed results from the ambulatory blood pressure monitoring. This is what I like to show you, that patients stayed with a very good controlled blood pressure in the ABPM. We can show here the randomized gastric bypass group and the controlled medical therapy group. They stayed very well controlled, but it's a little tiny here. But what I like to show you, that's the number of medications. The mean number of medications in the surgery group was 1 after 1 year, and is still in 3 after 1 year in the medical therapy group. Conclusion: very good control of the hypertension with less medication. And the editorial commentary for this paper from the Dr. John Hall and Michael Hall, it's an interesting term that I really love this term, that we are doing a cardiometabolic surgery. We published the 3 years outcomes in Annals of Internal Medicine, and I would like to show some highlights from the third year's publications. The first highlight was published in the International Journal of Obesity, because part of the patients did polysonography that doing in the home, at home, polysonography at home, not the complete polysonography. And what we showed here, that many patients had severe sleep apnea. You can see here in the medical therapy group and in the surgical group. Most of them had moderate sleep apnea in the surgical group. And after 3 years, this is results from 3 years with home polysonography. What it's a very interesting in a randomized trial, that 70% after 3 years was normal about sleep apnea. And what happened in the medical therapy group, there is not too much change. Most of the patients are severe and moderate sleep apnea. Again, randomized trial showing a good results for sleep apnea. That is a disease that drives hypertension. Another study from after 3 years from the Gateway is we study the variables that could impact remission. We studied almost 6 variables, and the only variable that impact remission was duration of hypertension in years. The longer story of hypertension, less remission. That's why it's important to treat our patient as early as possible. Another variable that's almost significant, maybe if you have more patients, it was significant, was fasting insulin, showing the insulin resistance, but it's not significant, it's almost significant. And most important of this paper, duration of hypertension impacted negatively the remission rate of patients. And finally, after 5 years of follow-up, we published the final results of our trial in JACC. This is a very important cardiology journal. And what I'm showing to you now is the final results of the Gateway study. It's important to say that we randomized 100 patients, 50 for surgery, 50 for medical therapy. Many patients were assessed to find the 100 patients, and the 5-year results, it's about 44 patients in the surgical group and 40 patients in the medical therapy group. This is the result of the primary endpoint after 5 years. We still have a very good results. 80% of the patients submitted to surgery could reduce at least 30% of the medications and stay with a controlled blood pressure. And in the medical therapy group, only 13% of the patients could reduce the medications and stay controlled. This is the primary endpoint, as I said to you. Some secondary endpoints, this is the baseline as I showed to you, and after 5 years, patients in the gastric bypass group was a mean BMI of 28, and in the medical therapy group, we reached a stable BMI. We could not make the patients lose weight, but they stay stable after 5 years. That it is a good result for a medical therapy group. Remember, we did not use any GLP-1 receptor agonist because at that time, there is no GLP-1 agonist for obesity when we designed the trial. Insulin resistance, they are very resistant, the patients, and after 5 years, the reduction in insulin was very significant in the bypass group, and it was more resistant. The insulin levels were higher in the medical therapy group. Patients in this trial were not diabetic or has a very easy controlled diabetic, no insulin in these patients. And you can see here the baseline, the glycate hemoglobin, and we find a reduction, a very tiny reduction, and a very tiny augmentation in the medical therapy group. But this data is interesting. It's that patients in the medical therapy group are taking more glucose-lowering drugs from the baseline and after 5 years. That said, patients are getting worse in the follow-up if you do not do any very strong therapy. The same happened for LDL cholesterol. We we saw a reduction in LDL cholesterol after the bypass, also a reduction in the medical therapy group. But because of this, again, patients are taking more statins after 5 years from the baseline in the medical therapy group and less statins in the surgical group. This is very important, again, in this secondary endpoint. Inflammation, it's a huge reduction, very, very significant reduction in inflammation in the surgical group. This is important for the amelioration of blood pressure also. Of systolic and diastolic blood pressure, we can see here a significant reduction after 5 years in the systolic blood pressure measured at the office, and a stable diastolic blood pressure. There is no significance in this reduction from the baseline. But remember, patients are taking only one medication for hypertension, and the medical therapy group is still taking 3 medications. Lower blood pressure with less medication. This is the message from the Gateway trial. The ambulatory blood pressure did not show significance. There is almost stable blood pressure in both groups showed in the ambulatory blood pressure. But once more, I have to show you that the number of medications were lower in the surgical group. This is important for the cardiologists and nephrologists. Resistant hypertension is a very important disease, and it makes the patient to have a higher cardiovascular risk. And we have a few patients diagnosed with resistant hypertension, and after 5 years, 10% in the baseline, no one was with this diagnostic after 5 years. This is, again, a very important result, and we should study more patients with resistant hypertension and metabolic surgery. This is the last result, remission. Maybe it should be my primary endpoint, but at that time we decided different. And it's a very, very important result. 47% was in remission after 5 years of surgery, only 2% in the medical therapy group. With the Brazilian guideline, and other countries use this guideline, blood pressure under 140/90. And if you use the new American guideline, the blood pressure under 130/8, 40% of the patients had remission with this guideline. Very, very, very important result. My final message, I think it's important to say, after 5 years of following these patients, I, based in other trials as the SLIF PASS trial, and we use only bypass, but I think with the results we can find in the literature, gastric bypass is the preferred technique for patients with hypertension. Many patients in our trial, as I showed you in the first year, can leave the hospital without antihypertensive drugs. They leave the hospital with a controlled blood pressure. This is very interesting, but you must monitor these patients daily with the home monitoring. You should monitor them to see if they need to reintroduce medications. And this is also important for the surgeons. I think diuretics must not be used in the first 2 months, at least, after surgery, because patients cannot take a lot of liquids in the beginning of the post-operative time, and diuretics can impact negatively this patient. Then you should not use diuretics in these patients after surgery. And finally, I I used the message of the editorial from the third year publication in Annals of Internal Medicine. The doctor asked us, the earlier the better for surgery. And after these years and after all the data we published in diabetes and other disease, I think the earlier the better. We should treat our patient as earlier as possible to get them in better health. That's what I would like to show you. I'd like to thank everybody again, thank IFSO and thank IFSO LAC.
Thank you, Carlos. It was an outstanding presentation, very interesting, this paper done by a surgeon to share with us. And now we're gonna move on to our discussion with our panelists. I'm gonna present both of them. In the meantime, for the audience, if you have questions, please write it down, or we're gonna ask the panelists and the speakers. The first panelist will be Dr. Judith Price. She's a good friend and a famous clinical nutrition doctor in Santiago, Chile. She's an MD, Master in Science in Clinical Nutrition, member of the Center of Nutrition, Bariatric Surgery, Clínica Meds in Santiago. She's a clinical expert and technical advisor in obesity for the Ministry of Health of Chile. Welcome, Judith. And Judith, she did a big favor because she's replacing Marianela Ackerman, who was the doctor from Argentina, invited, but she had some issues with flight problems. So she is not here, but we miss her. But Judith is gonna do great too. Thank you, Judith. And the other panelist is a world-renowned surgeon. I don't see on the video now, Dr. Ricardo Cohen. He is the director of diabetes and obesity at Osvaldo Cruz Hospital in Sao Paulo. He also is the past IFSO Latin president, and he is the president-elect for worldwide IFSO. So we want to start asking a few questions to our panelists, and I give the word first to Judith, if you want to ask something to them or to make any comments, please.
Yes, first of all, thank you. And I'm replacing the unreplaceable Marianela. We all miss her. Thank you both for your excellent presentations. I have a question or a comment to Dr. Schiavo. All these benefits, we can see them much more in the gastric bypass, right? We know that sleeve gastrectomy is not as useful for severe hypertension. What do you think about that? And do you think that should be one of the, one of the criteria before we choose a bariatric surgery in this subgroup of patients?
Yes, thank you, Judith, and hi. It's a pleasure to see you again. Yes, I think because of the results of my trial, and I think the 10 years of sleeve pass show a very different result in remission when we compare bypass to sleeve gastrectomy. And I think probably bypass is more potent, and it can achieve these many points of physiopathology that link obesity and hypertension. And I think the bypass can really attack many points better than sleeve gastrectomy. And if you have a patient with hypertension, mainly if it's as you said, the severe hypertension, I think you should do a bypass and not a sleeve gastrectomy.
Okay. There's a question from the audience I'm going to ask Dr. Claure. It's from Dr. Hamid Hamdi Ramadan. He asks, it's about obesity or adiposity? And also, what are the long-term side effects of weight reduction, either surgical or medical intervention? Dr. Claudia?
Okay.
You are silent.
Okay. Thank you.
Yeah.
Thank you for the question. I think both mechanisms are important. Mechanisms underlying obesity-related hypertension are complex, so there are many interactions. But for example, in terms of kidney-related mechanisms of obesity-related hypertension, adiposity is the main driver, for example, because there's this fat infiltration, visceral fat infiltration in the kidneys that cause compression and inhibits sodium reabsorption and bloods some responses in the kidney, increases proteinuria, causes this hyperfiltration phenomenon, etc. So both are important, but I think adiposity in many aspects of the physiopathology of obesity-related hypertension is the main driver. In terms of adverse events of long-term adverse events of weight reductions and comparing surgical and medical interventions, for example, in terms of medical interventions and with these new medications, one of the many most frequent complaints of patients using GLP-1 inhibitors is constipation. That's one of the main complaints, but could be easily managed, and some abdominal discomfort, etc. Also, long-term side effects with some medications should be closely followed up in terms of different antihypertensive medications, electrolytes, some impact in eGFR when we use especially some medication combinations, for example, SGLT2 and RAS inhibitors that have been using more recently in patients with diabetes, overweight, etc., that could cause increases in serum creatinine, problems in potassium levels, etc. So you should follow up that closely and frequently. In terms of, I think, in terms of surgical long-term complications, what I have seen in the clinic that I follow up with these patients, most side effects are related with sometimes with electrolyte control. Sometimes the patients have hypokalemia, hypomagnesemia, so you should have closely monitor that, and also because of the effects of metabolic surgery in the long-term control of blood pressure, especially patients with more than 5 years after metabolic surgery. You have to place a close attention to your blood pressure control and maybe adjust your medication.
Thank you. I would like to ask Ricardo. Go on. Hi, Ricardo. Your comments about these two talks, and if you have any questions.
Thank you very much, IFSO Latin America, and on behalf of IFSO Global, we are very proud to be here promoting a very cutting-edge workshop on webinar on the treatment of hypertension. Dr. Claudia may set the stage for Carlos to show the importance of surgery regarding the treatment of hypertension, because treating obesity and its complications is to perform preventive cardiology. So you decrease non-fatal and fatal cardiovascular events. And I have some questions to Carlos. Actually, one of them he responded already. What would he do if he had to redesign his trial as the primary endpoint? And you answered that you would do hypertension remission other than what you design in the Gateway trial. And the two other questions is, one is provocative, and why you think it's weight loss independent effect and not liquid diet with low sodium that promoted the early hypertension remission? First, and second, if you are responsible to design guidelines in treating people with obesity, clinical obesity, so the consequences of adiposity, and where would you place metabolic or cardiometabolic surgery in the algorithm for indication surgery versus the new medication. So guidelines and weight loss independent effects. Although I'm biased, I believe on weight loss independent effects of surgery. Even drugs shows this. If you look at the SELECT trial, or even the FLOW trial that Dr. Clary showed, the FLOW trial had people who gained weight and achieved remission of their renal disease and cardiovascular events. So what do you think it is? Low sodium or weight loss independent effects? And you're the guidelines man. How would you place surgery in these algorithms?
And Ricardo is my friend, and it's very easy questions. First of all, I think low sodium diet is important. There is no question about this. In the beginning, in the post-op, we use the diet is very low caloric and low sodium, and this is impact the blood pressure. But I really believe that there is something more than this, because in the Gateway trial, I think you have this in your practice. The patients leave the hospital without medications and stay forever without medication. This is very, very impressive to see in some patients that happening. And I think you said the results of FLOW. I think there is something more. I really don't know what's something more, and I think no one knows yet. For the second question, I think we need more studies in hypertension. Unfortunately, this is the only one randomized trial for hypertension. But as we are doing more severe cases, more complicated patients, the medications can manage the less complicated patients, I believe, with obesity. I think probably metabolic surgery will be an important treatment for patients with resistant hypertension, for example, because obesity is the most important driver for resistant hypertension. And maybe in patients with hypertension with higher BMIs, more than 50 or 60. But it's difficult to say because we don't have more studies and we don't have studies with resistant hypertension. But I think it's going to be an important treatment for this kind of patients, the more severe patients.
Resistant hypertension is the hypertension with more than 3 drugs, right?
Yeah.
Okay.
Including a diuretic, obligatory.
Thank you. Thank you, Carlos. A question for Judith and Dr. Claure. What do you think about a trial using GLP-1 analogs and diet for hypertension versus surgery? What will be your thoughts about that?
Thinking about what outcome? Like hypertension, resolution?
Yeah, remission of hypertension, yes. Do you think it has a role, is feasible, is the future? The drugs are getting better and better every year, and I haven't seen a trial comparing that. So what's your thoughts?
I think Dr. Claude can answer that much better, but at least what he presented now, it was in diabetic patients with I suppose semaglutide 1 milligram, and not for obese patients with obesity and hypertension. I don't think there is such a trial yet, as far as I know. I think it's interesting, as you said, every day we have more very powerful drugs. And I think that it could be it could have a role, in treatment. I don't know what Dr. Claure.
Okay.
Fernando?
I think that kind of study will not be feasible, especially for patients with extreme obesity. With all the data shown here and the recent study that was presented with from the last panelist, I think metabolic surgery has a great advantage in terms of more achieving goals of controlling hypertension in short term and in long terms. And these new medications should and will have an important role, but I think these drugs maybe will have a more important role in the long-term control of hypertension, especially patients who already have CKD, because in this population, after bariatric surgery, removing the antihypertensive medications is usually more complicated than patients with no CKD, no proteinuria, and when they go under bariatric surgery, they still will need a more close follow-up. They still will need some antihypertensive medications. I don't think a study of with a great number of patients comparing bariatric surgery with just medical therapy will be feasible, especially with these studies that we have presented, because metabolic surgery has an advantage over just medical therapy in terms of weight reduction and in terms of achieving hypertension control.
Thank you, Rolando. Carlos, one second, Carlos, were you able to compare the economic impact of in your trial between using medications versus surgery in the long term?
No, Marcos, unfortunately, no. We did not do this, but I can say you that in hypertension, if you only consider the drugs price, it's difficult to compare because usually they are very cheap drugs. But if you could evaluate the risk of the patients, the worsening of the patient that do not were treated, probably surgery will be effective in costs too. But if you only see the price of the drugs, maybe not. It's different from diabetic drugs.
Okay.
It's more difficult to compare because you have to see the global burden of the disease, not only the costs of the treatment.
Thank you. Judith, you had some comments?
Yeah, a small comment. I think that maybe it could be interesting to compare, for example, patients that underwent sleeve gastrectomy and add them a GLP-1, for example, and compare them with a patient with a gastric bypass, for example, thinking about the metabolic effect or adding this metabolic effect, and to see if maybe that could be they could have a role in that kind of patients.
Okay, good. Ricardo has a question there.
Yeah, I have a comment. I don't know if I agree with Dr. Rolando. I think we need randomized controlled trials comparing the new drugs versus metabolic surgery in all the fields, and there's no head-to-head comparison. If you look at the only randomized controlled trial with kidney outcome, it's ours, published 2 years ago. It's called the MOM study. It's published on Lancet Clinical Medicine. So, and in the medical arm, we kept GLP-1 receptor analogs plus SGLT2 inhibitors. In the randomized gastric bypass group, we kept the ACE inhibitors and the ARBs, and surgery with drugs was more potent in reducing microalbuminuria than drugs alone. So, and they were liraglutide, not semaglutide. So I think we still need head-to-head comparisons. They're feasible. The cost of using novel modern pharmacotherapy, it will be more expensive right now, but the prices tend to be lower over time. So I believe that yes, we need head-to-head comparisons of surgery versus the best available pharmacotherapy. And I agree with Carlos. I think that he mentioned that we're gonna operate people more sicker patients with higher BMIs, with more complications of adiposity. So we need studies comparing both, and we need studies comparing surgery plus medicines versus surgery alone to see if they're cost effective. They're really in the good outcomes persist with surgery plus medication. So we don't know if drugs are better than surgery so far. And if you look at the SELECT trial published on December, weight loss was 9.2%. They decreased with semaglutide 20% of non-fatal cardiovascular events. And today, semaglutide is in the label for a cardiovascular effect. It's in the label of Wegovy, of semaglutide 2.4 milligrams, that is for weight loss and to decrease cardiovascular events. And we need surgery. That's why I asked Carlos where he will put in guidelines, because we need to be in guidelines and in the labels, quotes, that surgery is effective and cost effective. So that's why we need trials.
Perfect. I have a question for all the panelists and speakers. We do know now, we have plenty of medical evidence about the impact of bariatric surgery, metabolic surgery on diabetes, metabolic syndrome. Now we have this about hypertension from Dr. Schiavone and Cohen. So why we're still operating only on 1% of the population, eligible population for surgery? It's a more philosophical question, but we keep talking about that. So for the president-elect, Ricardo is the first one who would like to ask me that questions.
The answer is easy. The answer is easy. It's not science, it's not data. Although we need level 1 evidence to show that metabolic surgery has effects on cardiovascular mortality. We don't have it. We're running one, a multi-center international, but we don't have level 1 evidence so far. So regarding evidence, we have evidence for diabetes, for weight loss, but we don't have for cardiovascular events. So this is one of the reasons, but it's not the strongest reason. The strongest reason is people and most of the healthcare providers worldwide believe that treating obesity is lifestyle interventions. It's diet and exercise. So while we have an excellent product, and I think for drugs and for surgery, we have excellent options. Surgery has 1 to 2% of penetration. Drugs has 5 to 10% of penetration, depending on the country. So still, we have over 90% of people not undergoing treatment. And this is because it's a wrong perception that obesity is a disease based on mental issues, is bad choices, that people with obesity are losers, and lifestyle interventions will do great according to the patient. We did a research between 1,000 patients, US-based, last year. And one of the questions, for an example, is you have a BMI over 40 with diabetes and hypertension. What's your first choice of treatment? It's lifestyle intervention. If lifestyle interventions fail, what would you do? I would change my diet and I would change my exercise. And if you change your diet and exercise, what would you do? I come back to another healthcare professional to inspire me. Inspiration was the answer, to inspire me to new lifestyle interventions. So we're not losing for data. We're not losing for options for treatment of obesity and its complications. We're losing to a misperception that obesity is a behavioral disease. So this is why we're still not operating over 2% of the eligible population, and UDIT is treating less than 10% of people that are eligible for treatment.
Thank you.
Yeah, I
Judith,
agree.
what do you think? Judith.
No,
And
I couldn't
Rolando.
agree more. I couldn't agree more. And I'm happy to listen this. And I don't say this often about a surgeon, so I mean, I really agree about what you're saying. And I'm now advising and helping the Ministry of Health here in Chile to implement our guidelines, the Chilean guidelines that were adopted from the Canadians one. And actually, that's one of the main barriers that we can see about the obesity treatment in general, not just about patients eligible for bariatric surgery. So our authorities don't have this new knowledge about what obesity is and where it comes from and how we should start working now about it. So I actually agree, and I think that our role as scientists and medical doctors and clinicians, it's actually to educate our colleagues in the first place and educate public health professionals and to advocate for this new knowledge in order to our politicians start taking the right decisions about how to treat this disease.
Thank you very much. I think we have to close. Dr. Aparicio, our IFSO Latam president, asked me to close this excellent webinar. I would like to thank all the panelists. I would like to thank the speakers. We had a great session of knowledge and discussion, and this has been recorded, so you can review that afterwards. Thank you, IFSO Latam. Thank you, Sergio. Thank you, Ricardo, Carlos, Rolando, Judith, and Sergio Aparicio for your support and to make this an excellent webinar. Any final comments before we close? Sergio.
No, thank you very much, Marcos. Excellent moderation. And thank you for the speakers and the panelists and, of course, all the attendants of this excellent webinar. Thank you, and have a nice day.
Thank you. Bye-bye.
Thank you, everybody.
Ciao.
Thank you. Bye-bye. Ciao.